Hello everyone, welcome to another series in the Academy of Online Radiology Education. My name is Ricky Olmstead. I'm a radiology resident at the Baylor College of Medicine in Houston, Texas. This month we've curated some interesting literature in abdominal radiology. I was helped out by Dr. Alice Fung, a body imager at Oregon Health and Science University. This article from AJR discusses stump appendicitis, a relatively uncommon but important pathology that is characterized by inflammation of the residual appendix after appendectomy. This was a case series of 14 patients from the University of Wisconsin, which demonstrated that stump appendicitis has similar imaging features of regular appendicitis, with the range of cases occurring anywhere from 1 month to 17 years after appendectomy, with a mean time of about 5 years. The article suggests initial laparoscopic appendectomy is a risk factor for stump appendicitis, as laparoscopic technique leads to a decreased field of view, which can make it difficult to visualize the appendiceal base. Additionally, if the initial appendicitis was complicated by perforation, necrosis, or abscess, visualization of the appendix base becomes more challenging and can lead to subtotal resection with a higher risk of stump appendicitis. Next, this brief radiographics article has a more thorough digital presentation to go along with it and gives a good overview of MRCP. A few advantages of MRCP over ERCP include being non-invasive and giving a wider field of view of the biliary system, whereas ERCP may not be able to see past a biliary obstruction. Disadvantages include cost, spatial resolution, and inability for intervention. The article discusses normal variants of biliary anatomy before discussing pathology, including choledocholithiasis, cholangitis, trauma, and malignancy. Pitfalls of MRCP include misinterpretation of artifact and normal variants that can mimic pathology. This was an interesting discussion in AJR on the utility of ultrasound screening or surveillance for patients at high risk for hepatocellular carcinoma. Ultrasound is commonly used as a first-line test. Some of the arguments for ultrasound include availability, cost, and ease of procedure. The sensitivity of ultrasound has been shown to be as high as 80%, with the specificity greater than 90%. The pro-ultrasound authors state that cross-sectional imaging may be more accurate, but that does not necessarily make it the better screening test. The counterpoint authors argue that CT and MRI are better due to their superior ability to diagnose early HCC, while ultrasound struggles to detect potentially curable disease. Cross-sectional imaging has the ability to fully characterize lesions with one scan, whereas patients with a positive ultrasound will be referred for CT or MRI anyways. This next multi-institutional article, published in Radiographic, looks into gunshot wounds of the abdomen and pelvis. The article discusses the importance of imaging in evaluating penetrating trauma, including important findings on initial presentation and follow-up exam. The article begins by discussing the physics of ballistics, trajectory analysis, and mechanisms of firearm injury, which have typical injury patterns such as laceration, cavitation, and shock waves. The article mentions that there are multiple schools of thought when it comes to the proper imaging protocol for evaluating gunshot wounds, and there is not one consensus agreed upon protocol. The authors then discuss the evaluation of solid and hollow organs, briefly discussing the widely used AAST injury scale for each organ. Musculoskeletal, neurologic, and diaphragmatic injuries are also discussed. This next article was published in Abdominal Radiology by a team from France. Cystic lymphangiomas are common in the neck and axilla, but can be associated with any lymphatic vessels, including in the abdomen. The abdominal variety makes up about 5% of all cystic lymphangiomas. On imaging, they appear as multilocular lesions with homogeneous serous content, a thin wall, and thin septa. They should be anechoic on ultrasound, fluid attenuation on CT, and water signal on MRI, with low T1 and high T2 signal intensity. The walls and thin septa may show slight enhancement on post-contrast imaging. Cystic lymphangiomas may become heterogeneous from hemorrhagic, infectious, or inflammatory changes. There's a wide overlap between cystic lymphangiomas and other pathology, such as loculated ascites, walled-off necrosis, and duplication cysts. ACLs are benign lesions that do not require treatment. However, surgical resection may be indicated if the lesion becomes symptomatic. This next article was published in Abdominal Radiology by a group out of Germany. The authors created a scoring system to characterize intra-abdominal fluid collections in postoperative patients. The article begins by discussing the different types of fluid collections after surgery, including seromas, hematomas, abscesses, and so on. The scoring system looked at serum CRP levels, gas within the lesion, and attenuation on CT, as well as contrast enhancement. A score of greater than or equal to 5 was found to be 85% sensitive and 79% specific for predicting infection in these fluid collections. The authors state that using such a scoring system may allow for improved patient management. This radiographics review article by a group from Brigham and Women's Hospital looks at the spectrum of duodenal emergencies, including primary duodenal pathologies such as peptic ulcer disease and regional pathologies that affect the duodenum such as pancreatitis or acute cholecystitis. The article briefly discusses duodenal trauma, which although rare can be life-threatening. The article provides a handy breakdown of duodenal pathologies by segment, with ulcers commonly affecting the first segment, duodenal adenocarcinoma in the second segment, pancreatitis in the third, and malrotation affecting the fourth segments. This next article from AJR looks at the natural history of MRI findings in children after endoscopic removal of a button battery from the esophagus. This case series from Emory looks at 19 patients found to have tissue necrosis or mucosal erosion on endoscopy. The authors state that MRI is a better imaging modality due to better soft tissue resolution and lack of radiation. They only use CT at their institution when MRI is contraindicated. Early MRI findings within the first 48 hours after endoscopy include edema, regional fat enhancement, and mucosal irregularities, including findings concerning for esophageal diverticuli in 40% of patients who had proximal esophageal injury. These were solved on follow-up MRI. Later MRIs demonstrated persistent soft tissue edema and mucosal irregularities. Fluoroscopy can also be used and demonstrated a contained leak in 4 of the 19 cases, ulceration on 8 cases, and mucosal irregularities on 16 cases. This next radiographics article from Beth Israel in Boston discusses pancreatic ductal adenocarcinoma. The article begins by discussing the epidemiology and poor prognosis of pancreatic adenocarcinoma with a 7% 5-year survival rate. The authors suggest a thin-slice multiphasic CT protocol is optimal for evaluating pancreatic masses. Pancreatic adenocarcinoma typically presents on imaging as an indistinct, poorly enhancing mass that obstructs the adjacent pancreatic and bile ducts. 10% of pancreatic adenocarcinoma may be isoattenuating to normal parenchyma, and indirect signs, such as ductal dilation, may be the only indication of a mass. The article briefly mentions the various histologic subtypes of pancreatic cancers, including adenosquamous, colloid, hepatoid, and medullary. Lastly, this abdominal radiology article from Thailand looks at the different types of fluid collections in the abdomen or pelvis which have the suffix cele. This comes from ancient Greek and translates to tumor or cavity. Most celes are incidental findings, but some can cause symptoms. The article discusses imaging features and diagnostic clues for each of the described celes. It includes overviews of common lesions, such as hydroceles, varicoceles, and mucoceles, but also includes less frequent abnormalities, such as Santorini celes, hematoceles, and syringoceles. Clinical history is important as it plays a role in narrowing the differential diagnosis. For more details, you can read our blog, where you can find links to the original publications. Please feel free to share your thoughts and questions on our forum. I'll see you next month.